All right, we're back. Senate Health and Welfare, and it's still March 12th. We're moving on to S-114 with Michelle Childs. Thanks for being here.
Sure.
So why don't we go through the draft? We did work on some language last time, so why don't you take us through what you have?
Sure. How's that for folks?
Looks good.
Okay. So for the record, Michelle Childs, Office of Legislative Counsel, and we're looking at a first pass of an amendment to S-114 regarding the psychedelic therapy advisory working group. So what I did to just kind of get the ball rolling for you so we could fill in the blanks is I wasn't sure if you wanted to continue to have findings and if you wanted to pull some of the findings from the bill as introduced or add some new findings based on your testimony that you've heard the week before last. So I just put a placeholder in there for findings.
I think it might be a good idea, and I'll let the committee, some ledge councils don't like findings. I think that they're, in this case, where it is a new topic that folks are not familiar with. Some people, but I think it's a good idea to have some findings.
Obviously, completely up to you.
Yeah.
I'm not passing any judgment
No,
one way or the other. I just
understood.
thought that since you did hear from some local folks, and I think what I
I
had
think
done
so.
when I initially drafted was pulling kind of more national data.
We have Vermont
studies.
data now and research that can help inform the bill, but.
So that's just a placeholder there, and then you'll recall that the bill is introduced, had a section 2 that eliminated the criminal penalties for psilocybin. So the working group is broader in scope than just psilocybin, so it talks about psychedelics, so it would be broader than that in terms of the working group. The decrim was just on psilocybin shoot, but that's out. So there's no changing at all of any penalties under state law or any psychedelics at all. And so your new section 2 is on the working group. And you'll recall that the bill is introduced, had it as a legislative working group, and it had 2 House members, 2 Senate members, as well as various appointees. And you said you wanted to take a look at it being more not a legislative, but having a group report to you. And so some of the issues just highlight is who do you want on that? I kind of just as a placeholder put in there the 2 issues, one being the looking at whether you would want to do something like the structured licensed programs that are operating in some other jurisdictions, but also the issue of looking at state laws that penalize psychedelics and looking whether you wanted to look at that from a public health standpoint, since some of your witnesses that you heard from before were talking about it from that standpoint. And so looking at it through the public health lens, not necessarily other things. So that those were the 2 issues. And you can do one or both or none.
Can I jump in for a second? Before we talk more specifically about the working group, can we talk a little bit more about the decrim? Or are we set on taking that out? Because I thought there was some really great testimony last week about the need for the change.
So I may agree with you on that. The only concern that I have at this stage is if the decriminalization is in the bill, it will then go to judiciary and they'll have to take testimony before they pass it out on promulgation. I issue. I think if we get this information back from the working group, it'll also then let us know what needs to be done around the conversation. So there is a section in the bill still about evaluating decriminalization.
Right, and the way I structured it was thinking about, again, kind of your jurisdiction of looking at health and welfare and
Yes.
and the witnesses that you heard from, and focusing on the health and welfare kind of risks and benefits of that, because there may be these other issues around, law enforcement and, things like that that are a separate issue, that might be better for judiciary or others to be looking at. But you can certainly expand this committee, you can have other people with expertise in those areas do it, but it sounded like you wanted to focus more kind of on hearing from healthcare professionals around if, how did they think that criminalization impacted.
To kind of go, it's like going back to cannabis and thinking about the use of medical marijuana. And that was big first step.
Well, so if the next iteration in the bill though is for it to go through the judiciary committee,
Yeah.
would it be helpful in terms of moving it along to have law enforcement on the working committee?
Well, let's go through the bill, and then that's a very good question about what exactly is the working group doing? Are they coming back with recommendations regarding decriminalization or solely on health effects?
Do you want me just to go through the language then of?
Yeah, let's go through it,
Sure.
and then we can then there might be changes to, this is all public health, health impacts, therapeutic use. If there might be some language changes in the first part of this.
So looking at section 2, subsection A for the creation of the working group. Purpose is to examine the use of psychedelics to improve physical and mental health and to make findings and recommendations regarding the advisability of the establishment of a state program. And I just picked Oregon, but we can just say other jurisdictions or other locations because they're coming on and, Colorado as well. And Connecticut is looking at it as well. So maybe just other jurisdictions.
So Oregon has decriminalized, I do know that, and now they, from what I've read, they were considering, going back.
Well, they have they have a certain type with
Yeah.
regard to all drugs,
Yeah.
but then you have Colorado that has decriminalized just psilocybin.
Yes.
And so, this is obviously constantly evolving with the state, so it might be, so things stay fresh, it might just be better to say, looking at the establishment of a state program similar to other jurisdictions to permit healthcare providers to administer psychedelics because it varies from state to state, with what's
Yeah,
being allowed.
Let's do that, let's make it.
Keep it general.
Sure. So to permit healthcare providers to administer psychedelics in a therapeutic setting and the impact on public health of allowing individuals to legally access psychedelics under state law. So I tried to just make that broad. I was doing it through a public health lens, but you could expand that if you wanted it to be looking at other issues or have other folks weighing in on that. And again, we're always just talking about what you do at the state level because you don't have any effect on what's going on at the federal level.
The term therapeutic setting is that intended to mean that it would be in some kind of facility or is it just, it could be at a doctor's office?
Could be at a doctor's, it doesn't have to be a necessarily, so like it depends on what model is being used, and I think that's kind of one of the things that they would be taking a look at, or what are the different models, so it's like Oregon may be doing it one way, Colorado doing it another way, there's other places certainly in Europe that are doing things like that, and so I think it would be part of them to say, this is the context, these are, if they decide that they want to recommend allowing it in some circumstances, then they would be telling you, this is how we think,
Right.
these are the, the boundaries of this is what we think it should be licensed, there should be training, like if you look at what's on the Oregon website, it goes, they've got great materials about what's required to be being a facilitator for
Right.
someone, and
I just want to make sure that the term therapeutic setting doesn't presuppose that it would have to be like in the state hospital or in
Right. I'm happy to use whatever term, I just,
Is
that
there a
was a term that.
definition of therapeutic setting anywhere in statute? That's the question, and if there is, then we don't want it to adhere to any.
I don't know, but I can certainly
Yeah,
ask your
okay.
healthcare team. I think it was just a term that I
Yeah.
kept hearing in discussion of this, and it seemed to me to be quite broad and not indicating that it had to look a certain way.
Okay,
or
as long as it's broad, I'm fine with that. I just didn't want it to be too specific.
Right, I would love to check. So that's just the creation, just like the general statement of why it's created. So I'm open to, again, I was just trying to kind of, get something to get things rolling, but open to suggestions on that if you, wanna tweak that. For the membership, I just left it open. I didn't know if you wanted to pick some of the folks who were on the list of the original working group or how you wanted to structure that.
But let's come back to that. Let's go through the bill and come
Okay.
back to that and look at what was on the original working group. And then I think Martine has given some thought to
Okay.
additional.
Okay, so I'll finish walking through this one. So subsection C, I just tweaked it a little bit from the bill as introduced. So the working group will be reviewing the latest research and evidence of the public health benefits and risks of clinical psychedelic assisted treatments and of criminalization of psychedelics under state law, and looking at it through a public health lens. And examine the laws and programs of other states. I might just change that to jurisdictions because I think some of the witnesses talked about places that weren't in the states.
So, and criminalization, I mean, the group probably can take it pretty broad.
Mhm.
Yeah.
And then also, the necessary components and resources if Vermont were to pursue such a program. So again, some of the witnesses have talked about, well, there's these programs, but they're really cost prohibitive for vast majority of people to access that. So, having these folks come back and talk to you about how, and that's actually the fourth provision on there that was in the bill as introduced, which is, looking at, universal and equitable access for folks. And subdivision 3 from the bill is introduced around allowing folks with lived experience to testify in the setting. So subsection D, just a placeholder, since it wouldn't be a legislative committee, you'd have to decide who's gonna help them with kind of getting meetings organized and developing a report that would be due back to you. The report will be due November 15th. I just had selected that date because it allows the report to come back to folks and then for someone to request legislation to be drafted if someone would like to do that based on the report. Then for meetings, it's going to be whoever is going to be staffing it would call the meeting together. Some just language, some standard language that we have in there around electing a chair, having a quorum. I did keep in a provision in there for per diems and compensation, just as a particular for y'all to discuss whether or not you wanted to have those available to folks. And then change the effective date because the bill was introduced last year, so have an effective date. So you want me to go and change and go back to the bill as introduced?
And they'll look at the working group, because then that will help direct who calls the first meeting and offers administrative. And we'll put some findings in. We don't need to have a massive list, but
I like findings,
I do too.
but I've been told that the Senate doesn't do findings, the House does findings.
It depends on the will of the,
Yeah,
I don't
and
like
y'all can do whatever you want.
so.
But it's your bill, you can put findings in it.
Well, it helps give people a quick intro to the topic as they're looking at the bill, but it could be helpful.
So you'll see there, I just skipped over the legislative appointments.
Yeah,
is
get
that in
rid of
addition
that,
to
get
the-
rid of those.
Yeah, there's none, I don't have those in your next draft, but the other members were, member appointed by the Psychedelic Society of Vermont, Behavioral Pharmacology Research Unit of, at Johns Hopkins, someone from OPR, and someone from Decriminalize Nature. So I'm sure you guys are already aware, but if you're you know, it's kind of one thing if you're creating a legislative study, it's another thing if you're creating a study with agencies and administration that you're asking to report back to you. This is looking like kind of a different animal where you're asking people that who really have no obligation to respond to you at all. To get together and work on this. So I just say that to kind of keep in mind around, you know, checking with folks who would want to participate or able to participate and that sort of thing. So I know you had mentioned having someone from UVM or.
So the question that we had around UVM was actually mentioning, well, Johns Hopkins is up there, so we could put in someone from UVM, the dean's office at UVM. I'm just saying you could name UVM
Yes, there's that.
from the Warner College of Medicine.
Yeah,
It would be, can you just tell me, because I don't typically do, so it'd be the University of Vermont.
Vermont College of Medicine, Warner College of Medicine, LA or and College of Medicine.
Appointed by, you said the dean?
Yes, what's Charlie McLean's title? Is he assistant?
The dean of primary care.
Is he the dean of primary?
I believe
so. Okay, thanks. But he's the one that's done all the research on it.
So would he appoint himself?
He
That
could,
might
yeah,
be a
no,
little
he could certainly,
But also, wasn't the testimony that there was someone
yeah, he had,
who was doing
Yeah.
pain management palliative care,
Yes.
also UVM doing
Yes.
either studies or working with folks on
Yeah.
that, so.
and what we could say is, before we get to our chief, Senator Lewis, we could say that the working group it does say we'll reach out and connect with others, so there's no reason why someone else who's doing pain research won't be there.
okay, want me to read the other folks that we had talked
Yeah,
about?
let's see what that sounds like, and then we've got people in the room who can help us with this.
So we talked about someone from Brattleboro Retreat. Someone from the Vermont Psychological Association. And apparently they agreed to staff it. So.
Call the first meeting and provide administrative assistance, and he's sitting right behind you.
Oh, it's nice for somebody to volunteer.
We're gonna have him testify.
Usually we're gonna have them to
Testify.
twist some arms.
Someone from the Board of Medical Practice.
And who would
But
appoint?
is it the Board of Medical Practice that we want here?
Jessa Barnard, Vermont Medical Society. I would suggest it just because there could be licensing and sort of regulatory
Okay, 'cause we already
implications, and
have
you have
OPR.
OPR, so this
Yeah,
would be for
that's
the physician
okay.
side.
And so who would be the appointing person for the board? Would it?
The executive
The
director.
executive
It would be the
director
executive
or
director, not the
designee.
chair, or. I just don't know what you guys typically
I
do.
think it's typically the executive director.
Yeah,
Why is OPR on it?
like,
I think that was, again, as the bill is introduced, was because there of people who would be licensed potentially under OPR. Then if they have whatever kind of system might be considered for having facilitators, it might be someone who also holds a license that OPR regulates.
That are not doctors.
Correct.
Okay.
Correct, and so I would say,
Counselors.
just a question that I've had, and you know, the issue is new to me too, but is I've kind of wondered about people who are licensed healthcare providers, who, even if you enable all of this at the state level, you know, what kind of jeopardy are those folks in at federal level, because it's still you know, is still Schedule 1, and I think you would certainly want this committee looking at and understanding what kind of risks there might be for licensed medical professionals if they did do this, so.
Commissioner of Health or designee. and a member of the Vermont Psychiatric Association. As opposed to psychological. That's it.
Was VMS interest? No, okay. Double check.
You can coordinate with all these other entities.
Okay.
Thank you.
And then, so,
How many is that?
well. Is it just these folks, or there's still some of these folks
The
on?
original 4 without the legislative folks.
Okay. Okay, so you have 10 people.
Why is Johns Hopkins on?
Doesn't need to be, I think that, again, this bill kind of started where I was working with House members for a while, and, I think those sponsors had communicated with researchers at Johns Hopkins, they were willing to participate at that time.
Mhm.
And since they had, and I'm not gonna remember the name of, but they have like a division or something at Johns Hopkins that is doing a lot of work with psychedelics, or kind of like known
It seems
leaders
to me
in that
that,
area, so.
yeah, it seems to me if Vermont UVM has people doing this research, we should just stick in house, but then aren't they supposed to, isn't there some language about them looking at research?
Oh, yeah,
in
they're
other
looking at
places,
all
so
this
could
stuff, so they
still
can take
look at-
testimony from folks.
So we could
At
say,
Johns Hopkins.
direct them to work with or to, make contact with,
I don't even think you have to do, I mean, I think they're so well known on those programs, so I think you could, you know, you don't necessarily need to say, I think the people who are practicing in this area are gonna be looking to
No,
that.
yeah,
so
they're gonna
take,
know that.
are you suggesting to take out Johns Hopkins?
It just seems weird to me that we
Yeah.
would have them on one of our committees, but
I would
I
agree.
mean, I don't care.
I also
how
think that
much.
you would wanna circle back, you would wanna, somebody would wanna connect with them to make sure that this is something now
Right,
that
we
they
haven't
wanna.
done that.
Yeah, and coordinating with somebody out of state might make it harder to meet, especially with 10 people. But
I personally kind of like that we've got them on the group just because it, I don't know, it broadens the membership, it broadens the scope, I think there's a certain cachet that comes with Johns Hopkins, me personally, but I will defer to the group.
Well, I think you're making a good point. It would mean that we will have to reach out to them and ask if they'd like to continue to be. Having someone out of state coordinating meetings. I'll look to the person who is,
We're very plugged into Johns Hopkins, so it's easy to connect with them. If you want to have them on there, it's fine. I don't know if they can make the time. I agree. Oh, sorry, Rick Barnett, Vermont Psychological Association. Yeah, we could make it work. It's also awkward to have an out-of-state person to try to coordinate that, but
is there language we can put in about soliciting information from Johns Hopkins, but not making them
I'm happy to add
part
something
of the
there.
working group.
So I will also just on this point then mention, I was just looking up decriminalized nature, because again, that was something that was asked for by the House members, but I don't know much about them.
I don't know anything about it.
And I think they are a national organization, so it's not, so just in going to the issue of there, do you still want to consider them? Do you wanna understand more about who they are, or do you just wanna kind of try to keep it to Vermont folks?
Mhm.
On the
I'm
committee who
happy
are
to keep it.
consulting.
Again, we could have the group reaching out to decriminalize nature without being a permanent part of the working group. So there are specific organizations we would like to have included in the discussion, but not maybe at every meeting. My other question is then, is who in the state of Vermont can talk about decriminalization?
Again, I think you, so are you looking at it from? Again, just the public
Yeah,
health scope. I mean, I would think that it would still be these folks, if you're gonna look at it from more of the kind of what the other impacts of decriminalization. separate than that, then I think you would have a different group of folks that you would add to this committee.
That's, yeah,
But it seems as though these people can, based on or certainly what they were testifying to, or saying based on the data, or based on, working with clients. They were sharing their opinions based on what was out there, but I don't know if there's. I would have to look more into this group, or you'd have to look a little more into this group if you wanted to include them about whether or not they're bringing something to the table that is
But I
not
mean, well, but
represented
you
by
know, I
folks
think
on your
uh,
committee.
it makes sense probably to have those two more specific organizations until we have more time to take further testimony at least. I think to have the working group reach out, connect with them and access the information that they have.
it just, again, from the testimony that we heard, it seems as though that I hear you about the public health piece of this, but it seems like the two are so intertwined. You can't access the therapy if it's criminalized. So it needs to be decriminalized to access the therapy, and so I just see the two as so connected, but if you all are seeing it in two buckets, then I can live with that too.
Think of the analogy about medical marijuana, which started a long time ago, and we worked really hard on that. And then we went to legalization.
Okay.
And this one may happen faster. I'm wondering if James Pepper can offer some be helpful.
And I think I get what you're saying certainly, but again, if I'm thinking about like what the chair's good example of that is that when in 2004, when Vermont established its medical cannabis registry, right, and said, we're gonna eliminate sanctions for this particular use, so you could analogize that to, you know, if you created a program using it, you know, in a therapeutic setting, blah, 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 there are no penalties under this, right? Then the next step that Vermont went to a decade later, almost a decade later, was removal of criminal penalties, and there were just civil penalties for personal use outside of the medical program. And then it moved to, you know, so like there was like this gradual thing, so the decriminalization or the removal of sanctions, you know, can be done in a myriad of ways.
Thank you. That's helpful.
Okay, Senator Hardy, you had a question.
Sorry, I was gonna say something similar to what you said and what Michelle just said, that it can be in phases. And the first phase might be using it in a therapeutic setting, and then the second phase, yeah, so I think it is fine with having just these people to start with. And making the case from a medical perspective that it's important for it to do it.
Yeah,
Thank you.
therapeutic setting, hopefully, is a broad enough phrase that's gonna cover different types of therapies. Not, you know, won't be the medical setting, social services or counseling.
Right, but what I had heard the witnesses been talking about with regard to the decriminalization outside of the therapeutic setting was, they were saying that they felt as though, the criminalization that people were using, so again, I guess it's looking, you know, and that, the criminal laws then kept, that was a barrier to them discussing with their healthcare professionals, so I think it's more, they're kind of weighing in on that piece.
So hopefully that'll come out during this process. Go ahead.
So I understand the mechanics of how, but tell me again why we're doing this. What's the purpose of this? Just to experiment?
No, I'm not sure that I'll be really able to answer all aspects, you know, from every aspect of the question, but there is evidence today that some prohibited drugs like psilocybin and perhaps other psychedelics are very beneficial and therapeutic for people with specific types of disorders or diseases. One is depression. So having access to these drugs helps patients. So we're looking at this in the context of research that's been done in Vermont and what's happening across the country and maybe other other countries to understand how could we allow for access to psilocybin or other psychedelics that will improve health outcomes.
So where's the data?
That, remember the data that we've had from, Dr. McLean from UVM, he was one, and some of our other witnesses also spoke to it. There is controversy about this, obviously. If you go to Oregon, they're having problems, there may be problems in other states. So we can learn from other states that have taken a big step toward decriminalization, but there are also countries that are using this that have found benefit. So this step that we're taking is really, can we understand what benefits might be here in the state of Vermont if the next step of legislation is taken?
So why don't we just let the other states do it?
We are.
Because I understand, I saw Mr. Barnett, when you said that Colorado had done something, you started shaking your head no. So do we actually have the data that says what each state has done and?
Well, we don't have that, but the working group will have access to that. So they'll be able to look at the data from other states, other countries, and then say, that doesn't work in Vermont, but this does work in Vermont. This will fit what we might be able to do. And it's, so Dr. Barnett, would you like to
Yeah, just to-
introduce yourself for the record?
Yeah,
Dr. Barnett.
Yes, that's okay. Rick Barnett, Vermont Psychological Association and Psychedelic Society of Vermont. I was shaking my head earlier, but only because I thought I heard Michelle misspeak saying that Colorado had decriminalized psilocybin only, but they actually decriminalized 4 psychedelic medicines: dimethyltryptamine, mescaline, psilocybin, and I'm forgetting the third one. So that's why I was shaking my head. The data in terms of the decriminalized version of this, not the clinical research therapeutic side of things, is still being gathered. There's good data coming out of Oregon that people are accessing this tool. It's psilocybin only, not other psychedelics, so magic mushrooms. But it's cost prohibitive for a lot of people. It's highly regulated, so it's fairly safe, but it's expensive. So they're showing data's coming out now. They just put this together, it took them a couple of years to do it. They rolled it out, I think, about a year and a half ago. Colorado's still setting up their system. So we don't really have data on the decrim part. We got tons of data from a medical or safety standpoint in terms of the safety of these drugs, the clinical benefit of them. It's a lot of data.
So I remember seeing a newscast that Oregon has reversed their stance on decriminalization because of
Right.
the overdose deaths.
They had 2 bills that passed. One was Measure 110, one was Measure 109. The measure that decriminalized all drugs, cocaine, fentanyl, heroin, everything, that one they're walking back on now. They're not walking back on Measure 109, which is the licensed facilitated psilocybin assisted therapy or psilocybin assisted. They don't even call it therapy because it's not specifically for medical purposes there. It's just for anybody who wants to use it in a safe setting. So yeah, you're correct. They're walking back the total decrim, which is all drugs, and they're keeping in place the other one with the one we're talking about here.
I just think it's really important that we not conflate heroin and fentanyl and other drugs with psilocybin. They are very different, and I think we just should not be mixing them up together in the same. I just want to say that.
And we are, right?
No, we're not.
This is just about psilocybin and
Right.
similar psychedelics.
So while we have you on the register, we'll go away, okay. So you represent the Vermont Psychological Association?
Yeah.
And is that association interested in taking the lead on convening the first meeting and then providing some administrative assistance to the working group?
So I currently serve as the legislative chair for the Vermont Psychological Association, and we have brought up this bill at our past 2 board meetings. Each board meeting, all board members have been supportive of their being a member from the Vermont Psychological Association on the key stakeholder list. I cannot speak right now on behalf of the board saying that we are willing to do that, but I can say that there's a groundswell of support for efforts like this. And so our commitment to seeing this through in a healthy, well, managed way is definitely there. Several people who have testified, either submitted written testimony or provided testimony already, either here or in-house judiciary last year, are part of the Vermont Psychological Association. So there's a groundswell of support. I can't speak for them in terms of the volunteerism aspect of it, but I'm sure people are really happy about moving forward with this.
Okay, so, and maybe at your next board meeting, you could raise the question and, then we'll have to make a decision about how to convene the first working group and then,
Our board meeting is tomorrow night, so.
okay, that'll be great. Good. All right, good luck. All right, so Michelle, what have we got for the working group?
So the folks that you would have right now, so someone, from the UVM College of Learner Medicine and
Colleges?
College of Medicine, appointed by the Dean of Primary Care. Or
It just says associate dean, primary care.
So,
Associate Dean.
I would say just have it appointed by the dean. You don't want it to go under the dean to have the associate dean appointing people, right? Seems weird to have the associate dean appoint somebody.
I don't know. We'll sort that out.
Oh, whatever.
So the next one is someone from the Brattleboro Retreat, and who would you like that appointing authority to be? Person would be,
Oh,
The executive director or
CEO, president, presidents.
presidency, presidency.
Who is the president right now?
Currently it is Linda Rossi,
Okay.
but she is, leaving April 1st. And Steve Cummings will be taking over.
So next is someone from the Vermont Psychological Association, appointed by the,
Legislative chair,
That's,
appointed by the chair. It makes sense to have whoever's at the top.
Yeah.
yeah, I agree.
So chair, it seems weird.
The-
That's another issue you can bring up,
right, it's the president, the title is
the
president.
president.
president. So probably make it the dean too.
Yeah.
Yeah.
Dean. But is it the dean of primary care or just the dean?
I think it should just be the dean and then they would pick somebody who is done over it.
If y'all were talking law enforcement, I would know who all these people are.
Right, I mean, just,
Who's the current dean? Evan?
Richard.
No, Page, Richard Page.
Yeah.
Oh, yeah, that's good.
Okay, someone from the Board of Medical Practice, appointed by the Executive Director. Commissioner of Health or designate. So I had a question on that one. Do you want someone who is within the Department of Health, or could the commissioner appoint someone who is
What,
a practitioner or any person?
why don't we say that? Why don't we say something like, appoint a person with, interest in the issue we're talking about. So like either a practitioner or a board member, or someone within Department of Health. Could be any
Anybody
one
with
of
someone
them.
with expertise
Yeah.
in this particular area? Okay.
Probably not.
Someone from the Vermont Psychiatric Association. And then I can Google whoever
You'd
is
be the president.
president. Okay.
Mhm. Who's the president?
The current president is Lisa Catapult Friedman, that's like psychiatrist from Bennington.
Let's go with any distribution.
Um, and then, from the bill is introduced, a member appointed by the Psychedelic Society of Vermont, and might as well have an appointing person or chair or,
There are co-founders, there's nothing.
okay. Should I say co-founder? Or,
Sure, whoever's at the top.
and then the director of OPR or their designee. So, you've got 8 people.
8's not that number.
No, I think you start, when you get more than that,
No,
it's hard to even get a meeting to.
And so, and then can we add language about reaching out and making contact with Johns Hopkins and,
Decriminalize nature.
yeah.
Yeah.
The nature.
Sure. And so for now on,
And any others as,
sure,
any,
I'll do some catch-all. And then,
Anybody else you want?
so I have them convening the first meeting by July 15th.
huh,
And then the report due November 15th,
that makes sense.
if that makes
Yeah,
sense.
any
you know.
later that,
And then, what about, do you wanna, the staffing issue, leave that open now, or?
well, let's put tentatively in the Vermont Psychological
Okay.
Society, and then we'll look for, confirmation or not, and if there isn't confirmation, we'll go back to the drawing board.
Okay, and then what about per diems and expenses?
If they're not otherwise compensated for this kind of work, and I
Right,
don't see anybody on that list who wouldn't be.
right, and I think. And then with regard to, findings, did y'all just kind of want to look at the findings as they were introduced? And then also look at your notes or think about the testimony received, and then you could email me thoughts, or I could work with
You wanna work with Martine on
Martine
that?
on that,
Martine, or
or
would
you
you like
could
to work on
send me
that?
your thoughts about that, we can back that back and forth a little bit.
Fine with it, but if there was some consensus that we didn't need findings, I'm fine with keeping those out too. What do you think? I mean, they were pretty long, it was.
I mean, maybe go through what's there and see, which ones you wanna keep, and then oftentimes, when I'm doing findings, we'll kind of, and you can obviously organize this however you would want, but oftentimes, I'll start with a kind of Vermont specific and then go down to more of the natural, because there's a lot of the findings in there about, here's a study on smoking cessation, here's one on depression, here's one on, all the different things.
Yeah.
So, but if there's any specific Vermont information, either that you glean from the Vermont witnesses, or if you want to touch base with them around that, and then you can send me some suggestions and I can finesse the language.
Okay, that sounds.
So, and if there isn't, I'm looking at our schedule. We had something by Thursday,
Okay,
and then we have some time on Thursday and,
sounds good.
for cleanup, so. Do that. And if you get to a point where you think findings don't, just.
Okay,
I'll change it.
sounds good.
That's good, I think that's good, so now there are 8 on this working group, we're looking for the first group to begin meetings and to provide support. And then, Senator Bullock is looking at.
And so I'll do a new draft, I'll send it to you, and then we can just go back and forth.
That'd be good.
Okay, great, thank you.
Really, thank you. Right, so we've taken the decriminalization out, it's more of a therapeutic, bill, and, which is okay. One step at a time. Okay, thank you. Thank you. So now we move on to drugs, other drugs.
Other drugs.
Other drugs, thank you.
Thank you.
Thank you.
Keep us posted.
I will, yeah, I'll email.
Just email, copy Kiki and Martine.
I'll email.
Yeah.
Thank you so much.
Okay. So Jen, why don't we look at S98?
And hi.
Oh,
We didn't put it up, it's the same version we looked at last time.
it's the same one?
Yeah.
Okay.
Or do you want it up on the screen? Okay, sorry.
So procedurally, by Friday, committees have to vote on bills to make cross it.
Yeah,
And that's it for
no, they have to be out of committee. And that's it. Then we look at all the house bills that we have. Coming in. A little slow.
Okay, ready to. Good
Okay.
morning, Jen Carney, oh, teensy bit, but yeah. Perfect, right. So this is S98, this is the same draft 2.2 that we had looked at. I
Seems like 100 years ago.
No, exactly, before the break. This is an act relating to Green Mountain Care Board authority over prescription drug costs. And as you may remember in this version, we had the Green Mountain Care Board in consultation with its own technical advisory groups and other state agencies, exploring and creating a framework and methodology for implementing a program for regulating the cost of prescription drugs. Directs the board to consider options for and likely impacts of regulating the cost of prescription drugs, including experiences of other states that have prescription drug affordability boards, CMS's development and operation of the Medicare drug price negotiation program, other promising federal and state strategies, the board's existing authority to set rates, adopt rules, and establish advisory groups, likely return on investment of the most promising options, and the impact of implementing a program to regulate the cost of prescription drugs on other state agencies and on the private sector. Board will provide an update by next January and provide the plan by the following January 2026, including any proposals for legislative action needed to implement the program. It would create 2 positions at the Green Mountain Care Board to lead this work and appropriate $245,000 to the board from the Evidence-Based Education and Advertising Fund in FY25 for those positions. Gives the board legal assistance as needed from the Attorney General's office and appropriates $250,000 from that same Evidence-Based Education and Advertising Fund to contract with experts on prescription drug issues to help the board. Then we add in sections 2 and 3
we add the Green Mountain Care Board's prescription drug cost regulation initiatives to the allowable uses of the evidence-based education and advertising fund. So the first instance is in the B section and the second is in the fund itself. And then with CAF, the use of the funds, monies from the fund to support the board's prescription drug cost regulation initiatives will be capped at $1 million in any one fiscal year. There are a number of other uses of the fund as well, in existing law, and the act will take effect on July 1st.
Okay. Okay, go ahead, and then on your question, go.
Just going back here just a couple seconds, what's the marketing advertising fund? What's the source of that? Is that
It is the, so in section 2, it's a manufacturer's fee, it's a fee on each prescription drug manufacturer whose drugs are paid for by DVA for use by individuals in its program. Programs Medicaid, Dr. Dinosaur and B-Farm. It's based on the department's drug spending.
Go ahead.
to follow up, and do we know what this value of this fund will be?
Yes.
Yes.
Yes, it's an existing
Yeah,
fund,
that's
yes,
an
and I'll let
element.
you speak in detail.
He'll help us with this. I do have a question about, what would happen if we've talked a lot about Medicare and the Medicare, fair pricing. Using that as kind of a price limit begin when Medicare starts in 2026. Could we just say that's what we'd like to have?
So this is I think you asked me to go work with the board on a proposal, so this is what the board is proposing, is looking at various options for regulating the cost of prescription drugs, and including specifically in number 2 in the first section, in A2, looking at CMS's development and operation of its Medicare drug price negotiation program. So that's one of the things you'd be directing the board to.
Well, we could say,
Look
rather than saying looking at, why don't we just say shall use or utilize the Medicare fair price of the price limit?
Well, section 1 is having the board exploring and creating a framework and methodology for implementing a cost regulation program for prescription drugs. So if you wanted to direct them to start doing the work, the language would need to be different. This is sort of a step.
Well,
Back
or
from that.
when they do begin the work in 2026, then to use that fair price.
I mean, it's a policy decision for the committee. We're currently directing them to look at a lot of different ways of approaching this issue, one of which is looking at CMS's drug price negotiation program. The way this is structured, the board would come back and make some recommendations, would provide a plan for implementing a program and tell you what legislative action they would need to implement it, but it doesn't decide where the program starts or whether it's going to specifically take the model of using the Medicare drug price negotiation program. So I think you could decide to do that in the future based on what they're proposing. You could decide now to direct them to do it, which is more the model we were looking at in earlier versions of the bill. This is, I think, a reflection of the board's proposal for how they want to go about doing the work, but it doesn't have to be your proposal for
So
how you
the
direct
board
it.
is in the room, and I'm looking at Susan and Julia. Any comment on the question that I was using the Medicare fair pricing as an upper price limit?
Susan Barrett, Executive Director, Green Mountain Care Board, and Julia Bowles is also here. She can chime in after me needed. I think how Jen described it, it is one of the items that we would be looking at in our work to evaluate or explore different options. I would rather, personally, I would rather not make that decision now. I would keep it on the table as something to explore and consider. Do you have anything to add, Julia?
Okay.
I just generally, this bill started out with, having this bigger plan to regulate certain high-cost prescription drugs. And then we moved it down to the sort of low-hanging fruit kind of level, and now it's just a 2-year study and implementation plan for something that's really big. And given the crisis that we're in right now with the cost of prescription drugs, and we're seeing it play out with 30% of our school budgets going down in part because of the cost of healthcare. I just don't feel like this bill is meeting the urgency of this situation. And I'm a little disappointed that we're not willing to invest in what we need to invest in to move this work forward much quicker.
So what
People are
you're
getting
getting
like completely
wiped out.
wiped out by the cost of prescription drugs. They're getting completely, taken advantage of by pharmaceutical companies who are refusing to make their products affordable for Vermonters. And we're just
It's
doing
the
a
reverse. They're
2-year
making it
study.
Less affordable.
It's ridiculous. And they sat here and talked about their coupons. It was offensive, and we have to be doing more than this.
So, suggestion, what could we do in this bill that would take us a step further than what the bill is doing? So we go back to a prior iteration or draft of the bill. That's why I brought up the fair pricing issue. We could go and ask the board to do some initial look at low hanging fruit. Those are things that we could ask of the board. There will be, if we get through appropriations with the 2 new folks. Can the board do any work before 2026? I mean, that's a question that only the board can answer.
Susan Barrett again, there has been a lot of work done in other states. We would definitely work with them and try to understand what they've done. Julia has done that research already. I hear the frustration. We see it too in our regulatory work and the impact on our hospital rates from insurance rates. So, I mean, without having the staff, we cannot put this on top of the work we're already doing. But I could maybe brainstorm a little bit more with Jen, or you all could brainstorm and we could consider it.
That would be helpful. I mean, I wrote an editorial a week before I got sick on prescription drugs. And one of the things that stands out in all of the testimony that we've heard is that the specialty drugs, little brand drugs like the Humiras that were supposed to help people with arthritis have now expanded, and they're being marketed to any number of folks. And the cost has gone up 500% since the introduction of that drug. I mean, there's just some terrible increases that are going on that are the result of which comes out of people's pockets. So if there's anything that you can bring to us that would accelerate the process, and I know we've talked about this before, there's just so much you can do, but it would be extremely helpful for us to hear that. What we might do is ask for you to do that between today and Thursday. And then we have to act on the bill. It's always possible that between here and the House, something else can happen. Hopefully the bill will go forward. And no one has a problem.
Yeah, for the record, no one will join fiscal office. I mean, there's 2 positions being hired in fiscal year 25.
Yeah,
And then we're finding a report back 6 months later. You could move the program, and it doesn't need to be another year. It could be another 6 months after that. But you're hiring the staff to do the work. They can start doing the work. right? I mean, it takes a while, but like, they don't need till January 15, 26 to provide a plan, that's what they're hired to do.
Yeah, no, and I think that was in consideration of
Right.
what's happening at the federal level with Medicare.
Right.
So we could, if we're not tying our horses to Medicare, we can, do exactly what you're suggesting.
Yeah, and I was also thinking of reporting, I think the same line that Nolan was speaking of. I also just wanna say out loud with, once we get the funding, it takes many months to get the person hired even. And we can keep you all posted on if this all goes through, when we have someone in place and when we're starting to work, and we're very, we attract good people, so I would imagine we would find some good candidates for something like this.
Okay, so let's do this. Let's look at the dates. And at the dates. And Susan, please, you can look at, what can accelerate the process. Then we'll get to a good place. Remember the audiences.
And just on another note, I wanna just let you know, I did an issue brief on the RX fund and fee. I sent it to Kiki, asked her to post it, and I CC'd you too on it, so there's a little brief explaining what it is.
It's the evidence-based education.
Yeah,
Oh, the
Advertising
advertising.
fund and the fee
Oh,
that we
okay.
did.
That's
yeah,
good,
so I asked Kiki to post that,
Oh,
so that
good.
everybody can see it.
Good, yeah.
It's got the balance and the fund and how it's raised and what,
Yeah.
everything you wanna know about it.
When it started, did you have the rationale for when it started in terms of the drug detailing piece?
No, I just talk about what it is and, oh yeah, I have a little bit of the history, but not,
Yeah, historically.
yeah. Everything you'd wanna know.
Okay. Thank you. All right, so Jen, what are you hearing in terms of dates? I think Nolan made a suggestion that sounded plausible.
But it sounded like potentially moving up the date of the second report. I mean, it is an on or before, so it doesn't have to wait until January 15th if they're ready before, but you could move that date to an earlier date. You won't be in session, so to the extent legislative action is needed to implement the program, it won't happen until the 2026 session unless there is some, I mean, the board may see, as they are reporting to you in January of 2025, they may see some areas where they would need that legislative language, and we could include that in 2025.
That date, let's start with January 2025, that probably can't change.
I don't think moving the other date will have, to Jen's point, it will
Yeah.
not have much, but I think that we had earlier versions of the bill that actually invested in the people
Low-hanging
that we
fruit.
needed to give the Green Mountain Care Board so that they could pick that low hanging fruit. And I just wonder why we can't go back to that and
To hire 5 people.
yeah, I mean, if, you know, there's a lot of evidence that it could save Vermonters money and it could, you know, lower healthcare costs. It seems to me that it's just continually frustrating to have studies for urgent issues.
Well, the only thing
And
we
this
could say.
bill has just gotten watered down and watered down and watered down and watered down.
So, and it's really, what can we do? Economically, and what can the board do within what time frame? Those are the two things. The board has been insistent on having 5 people to do this work. And then we said, maybe 2 people can get it up and running. And with 2 people, can the low hanging fruit begin be picked? I can't answer that question. I'm probably going to be too realistic right now in saying that if we put 5 positions in here, it won't even see the light of day at the other end of the hallway. But the way it is now, it might have a chance of moving forward. But I agree with Senator Hardy that this is a real crisis that we have in terms of prescription drug costs. Should be doing something. Oh, anyway, we'll look for your response. Before Thursday. And then we'll see what we can do. There's no need to change the dates, it sounds like.
Well, we'll see what the board
Unless the board
back.
can amend with something. That would be helpful. All right, you've already started, I know Julie has been working hard and we really appreciate that. We appreciate all the work the board is doing. And expanding work is one thing, but having the people to do it. It's people. So, okay, so I think we're good. Is there anything else we want to look at in the bill? Any changes? Let's just zip through the bill one more time.
Sorry, I just got out of the.
Yeah.
Rejoin Zoom.
Well, while Jen's doing that, I just want to thank Senator Hardy for bringing up the urgency piece and for you, Chair, also for working with that, because I mean, all we hear is about, affordability issues in the state of Vermont. We hear from the administration, we hear from the agencies, we hear from our constituents. And if this is something that can help solve the affordability issue, that needs to be top priority.
Right. And I think the biggest concern that we've heard from constituents beside the high cost of drugs is, am I gonna lose my specialty drug? And the answer to that is, no, not gonna lose your specialty drug. The price might come down, but not gonna lose the drug.
So you wanted to look at the language again?
Yeah, let's zip through and see where we are.
Okay. So we have the Green Mountain Care Board directed to explore and create a framework and methodology for implementing a program for regulating the cost of prescription drugs. And to consider options for and likely impacts of doing that regulation, including the experiences of states that have developed prescription drug affordability boards, CMS's development and operation of the Medicare drug price negotiation program, other promising federal and state strategies for lowering prescription drug costs, the board's existing authority to set rates, adopt rules, and establish advisory groups, the likely return on investment of the most promising program options, and the impact of implementing a program to regulate the costs of drugs on other state agencies and on the private sector. We'd have an update on the status of the board's work by next January, and the board's plan for implementation of the program by the following January, including any proposals for legislative action that are necessary to implement it. Creates 2 permanent positions at the board to lead the exploration, development, and implementation of the program, a director of prescription drug pricing and a policy analyst for prescription drug pricing. It appropriates $245,000 from the Evidence-Based Education and Advertising Fund to the board in fiscal year 25 for those positions. It allows the board to have legal assistance as needed from the Attorney General's office. And it appropriates an additional $250,000 from the Evidence-Based Education and Advertising Fund in FY25 for the board to contract with experts on prescription drug related issues to assist the board in its work. Section 2 is the prescription drug manufacturer fee, which is an existing fee with a number of uses for the fees collected, the revenue from those fees. This adds the Green Mountain Care Board's prescription drug cost regulation initiatives as an allowable use. And section 3 amends the Evidence-Based Education and Advertising Fund itself. So where the fee revenue lands is in the fund, adding the Green Mountain Care Board's prescription drug cost regulation initiatives as an allowable use of the fund, along with a provision capping the amount of the fund revenue that would go to the board's prescription drug cost regulation initiatives at $1 million in any one fiscal year. And the act would take effect on July 1st.
Thanks. All right, so we got the picture. Our goal is to start sooner. Really, okay. So yes, we have a drug problem, we have two drug problems, one, we're fighting opioids, and two, we're fighting prescription drug costs. We're gonna do what we can for both of those. Okay, so let's call it a wrap.